I'm joined today by Ben Turney. He's a professor and consultant urological surgeon and associate professor at Oxford and the managing partner of Oxford Urology Associates. He's also the founder of Oxford Stone Group and has driven the introduction of multiple new urological treatments in Oxford over the years. So he's both a serious academic clinician and private practice operator. So such a rare and valuable combination to have contribute to this series. So thanks so much for joining me today, Ben.
Thanks, Ayla. Really good to be here and look forward to our discussion.
So I kind of want to know everything. Nikita from Carebit mentioned Oxford Urology Associates has grown into a multi-clinician, multi-site practice. Can you give me the quick version of how that happened? What were its origins and what does it look like now?
Yeah, so we started the group with just three of us back in 2014, 2015. We were all new consultants and we had all trained together, and the three of us decided we'd like to form a group. We had some experience of this because colleagues in Reading, where we did some of our training, had worked as part of a private practice group. But historically, most surgeons work as individuals, sole practitioners. But we were good friends, and we also had different specialty interests within urology. And we saw how well it had worked in Reading, and we thought that that's what we would like to replicate in Oxford. And we could see that there were lots of advantages for working as a group. As I say, one of the things is that you can retain your subspecialty interest in private practice. So many doctors maintain a sort of broader practice in their private practice than they do in their NHS practice. And obviously it's better for patients if they're seen by people who are doing high volumes of the same procedure or seeing the same types of patients. We think that offers a better quality of care for the patient. And beyond that, it's quite lonely sometimes working in private practice. You don't have the support of your team, and you're very much exposed clinically. And just being part of a group offers you some reassurance that you can get a second opinion, or you can refer a patient to a colleague if you need that, or even just discussing it. Because if you're working on your own in private practice, sometimes there's a reluctance to share information. And I think one of the concerns that people have about groups is, well, is the pie available? Is it a finite amount? And if you start working in a group, are you just sharing that pie more in thinner slices? But I think what most groups have demonstrated is that the efficiency of the group and the way that a group can scale actually means that the pie just gets bigger. And certainly that's what we found over the last 10 years or so, is that we've recruited more members. We now have 15 of us in our practice. We've expanded our geography, so we cover a wider area outside Oxford. We have members of our group working up in Banbury, Milton Keynes, Wycombe, and we're looking also down towards Swindon now. So the geography has expanded, the numbers have expanded, but we're not all sort of fighting for work against each other. We're actually synergistically working to kind of grow the practice. And it's been a sort of fun journey. I think a lot of doctors also don't have a lot of experience of running a business. They've trained in a public sector setting. And there's a lot of mystery and mystique about what happens in private practice and how it gets organized and so forth. So I think having a group really helps with that. And from a financial point of view, I think there are lots of advantages. We negotiate as a group. So for things like medical indemnity, we can leverage our group to get better rates. We have a secretarial pool, so that, with holidays and sickness and other absences from the secretarial pool, is cross cover all the time, which means that there's always someone available to take calls and to look after our patients. It's meant that we can adopt systems like Carebit, which you mentioned, our mutual contact with Nikita. we were keen to adopt something like this to facilitate more efficient practice, and I think that certainly has helped. And also, when we're talking to the different hospitals that we work out of, I think they are more keen to discuss with the group, because we can offer a sort of block of activity rather than individuals coming for asking for specific items or particular agenda things that they have that they want to sort out. The other thing from a practical point of view is I think it means we're supportive. So if one of us is away on holiday, or a patient turns up on a day that you're busy doing other activities, then there's a much more kind of cooperative feeling that we want to support each other in the group, which is really makes life better. So in short, I really can't imagine now not working in a group. I think I would feel very lonely, very isolated, and wouldn't have all these benefits that we've grown to sort of become accustomed to. That said, there are a few things that you have to get right at the beginning, and I would say one of the key things is to get a legal contract between the partners sorted out at the beginning. Something that's robust, not something that's been scribbled down on a bit of paper and everyone thinks is a good idea, but actually a proper legal framework, for scenarios such as someone's injured or can't work or goes on long-term sick leave. But even simple things like how to onboard new people, what are the rules, and also at the other end of the career, when people come to wind down at the end of their career, how they're going to exit from the group. And there are lots of different models available. The key thing is that everyone signs up to it and everyone agrees to it, and that it's enforced. I think partnerships usually run into trouble when the partners fall out or can't agree on things. And the two main things there, I guess, are one, financial. So you need to work out upfront how you're going to distribute the money that you obtain from private practice amongst the partners. What is the formula or the mechanism by which it's distributed? And then secondly, some of these rules and regulations around new partners joining, old partners leaving. What happens if someone inadvertently stops work, or these sort of scenarios, which fortunately are rare, but they do need to be planned for in the document. So I would say that's probably where most partnerships fail, is that people sit down and have good intentions but then just can't agree a framework which they're going to be happy with. That said, I think when you do sit down and have that conversation, there has to be an expectation that there's an added value from the partnership beyond just the financial. So perhaps people are prepared to give up a little bit of their percentage of revenue in return for the convenience and the benefits that the partnership gives. And so that sort of compromising is really essential. And sometimes a relatively small amount of money, people fall out over that, and that's what breaks the deal, when actually they'd be much better off just forming the partnership and moving forward with it. So I think that's where we are. And as I say, now in 2026, we're 15 of us. We've got a big geography. We're still growing. We're onboarding another person in the near future. And we're always looking to evolve the practice. So when I look back how we were 10 years ago, we had a pretty primitive sort of practice management system. We've always been paperless, so we've never had paper records, but we've moved and evolved, and now we're very happy with the Carebit system. And we've evolved how we do our indemnity. So we use commercial indemnity providers now, which are much more akin to the insurance that you would get for your car or your house, where you can look at more bespoke practice and get your indemnity quotes according to what you do. We look at our billing, so we actually outsource our billing, but we're always looking at how we can optimize the billing side of things. And we have to balance that with the amount of administrative support that we have. So when we started, we had a couple of secretaries. Now we have 6 part-time secretaries. So we run the payroll for them, yeah, so it's a really, we're actually now a sort of decent employer as well, which is great actually. So I think it's been a really really collaborative venture, which as I say, I would encourage anyone going into private practice to try and form or join a group. I think it's a much better way of delivering high quality care.
Brilliant. And you covered so much there. There's so many kind of many questions that I could kind of get into here. I think it's really interesting. So just to confirm, so you're all pretty much the same specialty, all urology. I mean, I'm sure there's like, you know, some things around the edge, but this is a specialty urology practice where you're all kind of working on the same sorts of patients with the same sorts of problems.
Yeah, so we're all, well, we're not, within our group, there are 2 uro-oncologists. So these are oncology specialists who don't do surgery, but treat cancers of the urological origin, bladder cancer, prostate cancer, kidney cancer, testicular cancer, so on. And they treat the non-surgical side, so the chemotherapy side of treatments. So they're part of our group because of their sort of affinity to our specialty. But then the rest of us are all urologists, and we all do sort of general urology, but we also all have a subspecialty interest. So for me, that's kidney stones and benign prostate enlargement. For others, it might be kidney cancer or prostate cancer, or you know, it might be andrology, fertility. There are lots of subspecialties within urology, but we all retain those interests. So if I see a patient, you know, with prostate cancer, I don't manage prostate cancer. So if by inadvertently a patient comes to see me who does have prostate cancer, I would then refer them on to my colleagues, so they get that subspecialty opinion and advice, which is, you know, much better for the patient, really.
Absolutely. And that's, you know, from a marketing standpoint, that's absolutely brilliant. Creating, you know, a niche or, you know, this kind of silo of the area that you treat is very much in keeping with kind of marketing best practices. It's much easier to kind of package and sell specialties in a way. So it's interesting that you guys kind of intuitively went for that. And it sounds like it's just gone from strength to strength. So that's really great to hear. And I think great advice for other people starting out. I'd also like to touch up, you mentioned, and we shouldn't name any names perhaps, but going from one project management software to another. What were like the motivators for that, or kind of what went wrong, and what you know changed with moving over to Carebit? Because I think it'd be really interesting. You know, it's learning from other people's mistakes and things that have gone wrong is always really helpful. So, like, what would you say? You know, if you're looking for a practice management software, or maybe just tell me about that. Expand on that a little bit. I'd be really curious.
Yeah, so I think when we started, we were very keen that we were paperless, and we thought we were very progressive in that we had a paperless system, and you know, we could email out from it, and everything was digital. So we didn't have boxes of filing notes that clinicians have had prior. And when some of our partners joined, they came with boxes of notes, and the first thing we were keen to do was just to make sure that they didn't write anything down, and everything became digital. So we were quite excited about that. But I think the problem we had was just that the efficiency of communication is absolutely paramount now for patients. And we had a system before where we would, well, initially we would dictate into dictaphones, and those were then transcribed by our admin team. And then we outsourced the typing to an online system. So they basically uploaded our digital transcriptions to a service, and then they transcribed them and sent them back, and then we had to proofread those letters, and then they got sent out. So the turnaround time for a letter there would be, you know, sometimes 2 or 3 days by the time someone had typed it, and then we'd had a chance to go back and review the letter. And it just became increasingly inefficient. And we were aware that the new platforms basically were allowing integration with AI. And there's a lot of talk, obviously, about AI in healthcare, but where I feel the advantage, you know, the low-hanging fruit here really is in the admin burden and reducing the admin burden, because, you know, there's a lot of communication. You know, patients tell us a lot of information. We have to document that, then we have to summarize it, and then we have to communicate that, but with a plan that the patient can understand. We have to communicate risks, and we have to communicate details for the consent process if they're having a procedure. And that's really where Carebit's transformed things for us, because I routinely use ambient AI now in my clinics to basically summarize the clinic consultation, and then that will produce a draft letter within a few seconds of the patient finishing the consultation. And then usually by the time they've got to their car to leave the hospital, I've been able to proofread the letter and email it to them and to their GP. So, patients are astonished. And when I do operating, often by the time they've woken up, they'll have a letter on their phone that they can read about the operation, which they really appreciate, because they want to know instantly what's happened and what's been done. So that's been really a fantastic transformation. But it also it builds in things like secure video conferencing, so we can have face-to-face calls like we're doing now with patients. It allows a billing service to be built in there automatically. So it really is sort of looking, we looked at quite a few different options, and we felt this was the best for our practice. And we can look at each other's diaries, and we can task secretaries activity, so we can ask them to do things, all recorded within the system. So for us, I would say it's really reduced our admin burden significantly. So it's that sort of thing where, as a practice, it takes us up a step in terms of our efficiency. And so that's where we're always looking for, where's that next step on the sort of improvement of efficiency, because I think from a patient perspective, they are a consumer of healthcare services, and they expect these days the healthcare service to be like Amazon or any online service where you can click and book and then be seen and get a result quickly. And so we have that facility now where patients can upload letters to Carebit or scan results from other sites. They can upload them to their record. We can push things to them, so if a blood result comes back, we can forward that to them through the system securely. So there are lots of ways that we're now just communicating more rapidly with patients, and I think they really, really appreciate that. It's not that long ago that we were actually posting out letters with stamps on, after clinics, and we've just left that behind, which is fantastic.
That's amazing. Yeah, with my conversation with Nikita, we did get into a lot of this, the idea that, getting these systems right really makes such a huge difference with patient outcomes and patient satisfaction. And, essentially from where I'm coming from in a marketing standpoint, having that, seamless interaction with your patients is just always great marketing. They're going to tell you got to go to this place because everything just works so well. So it's really great to hear you validate that.
Yeah, it makes a huge difference. And I think it gives them confidence also that the quality of the service is going to be high if everything runs efficiently. If you're trying to phone up and you can't get a reply, or leaving voicemail messages and it takes a while for someone to respond, I think you lose confidence in the whole system a little bit. So our goal has basically been to make it easy for patients, because if you're unwell or you're in pain and you're seeking treatment, the last thing you want to be doing is going through barriers to get the help you need. You want it to be available as quickly and as efficiently as possible. And again, that's another advantage of the partnership, is that because we're so many people, usually there's somebody around every day who can help in a crisis. So you don't have to wait a week or whatever to see somebody. You can usually we can slot someone in the same day if necessary. And I think the other thing is that the patients are changing the way they come to see us. So historically they would go to their GP would examine them, maybe do some preliminary tests, and then refer them on to a specialist. A lot of patients now kind of know what their problem is, or what bit of the body that's wrong, and they know who they need to seek, and so they just contact us directly. And so now with our website and with Carebit, patients can click on one of our specialists, and they can look at their availability and book straight in. So that makes it easy for them.
Yeah, and I guess, is that a bit of a paradigm shift that you're seeing now with kind of the expansion of private health insurance in the UK? Has that kind of changed the metrics, or why do you think that's changing so much with people going kind of straight to the source?
Well, I think that there are multiple reasons. One is culturally, I think people are more aligned to just booking online. Everything else we do in our lives, we book online, whether we're buying food or clothes or shopping or booking flights. It's all done online now. So everyone's very familiar and comfortable with, handing over their data to online bookings. I think patients often don't want the additional delay of having to see a GP. So obviously they've got to make an appointment or get seen, and actually that just introduces another step in the process. I think you're right. There has been an increase in the number of insured patients, mostly through, I think, work-based healthcare schemes. A lot of people are sort of asking for that or requesting that as part of their job package, and I think employers see the value in that. If patients are waiting for treatment, then potentially they're slower back to work or not at work. But there's also a self-pay market as well. So about a third of our patients are still seeking treatment that they're paying for themselves. So again, they're just looking to be seen quickly and efficiently.
So speaking of that, so how do new patients find you, and how has that maybe changed over time now that you've been kind of doing this for quite some time?
Well, we have a group website which has been up and running for over 10 years. We've had the same telephone number for all of that time. We have a single admin email address that patients can email in, and I think we rank pretty highly in all the search engine tools, and I think patients, as I say, I think most of them know what specialty they want, even sometimes what subspecialty they need, and so they're now just making an internet search and looking for alternative options, really.
So website has been kind of that's maybe the nexus of where your marketing sits originally, and then search engine optimization. And do you do pay-per-click advertising as well?
We have done in the past, but and it's probably something that we've under sort of utilized in the marketing sense. So when we started, we used to go and give talks at general practice groups. Usually they call them lunch and learn. So there'd be a sort of lunchtime talk with a sandwich, and then we'd talk about a topic of interest to them, or maybe just talk about referral pathways or things that they should be aware of. And the idea was obviously to make them aware of us and to do some education for them. But I think now we're sort of quite well established. And as I say, if you put Oxford and urology into a search engine, then we kind of pop up straight away. So we've sort of not been so active in terms of marketing. I think there are some changes, and I think it may be that in the future each surgeon may need to have their own website. So we might have currently have a group website with all of us on the website, but we may need to sort of supplement that so that people can really look in more detail at the specialties and the subspecialties within urology. And we're aware that with AI searches now, the AI really is only reporting what is available on the internet for it to look at. So it's very important to kind of position yourself so that AI detects you and make sure that you're visible to it, so that patients can find you easily.
Yeah. I mean, things are certainly changing there. I mean, I think that one of the good news things for you certainly is, like, for now, Google is still very much the vast majority, more than 95% of searches for people looking for, a provider near them are going to Google. And the fact that you guys have been around for such a long time in the same area, in a less kind of competitive market than London, makes it a little bit easier to rank for that. But having that authority over a long time, I would say actually, expanding your current website with numerous, like having everybody on there, I think having a great, kind of subspecialties page would certainly, bring the SEO up on that site if you really kind of delved into that. And then even having the individual consultant pages really fleshed out as that kind of authority for those, and then great internal linking, so that if you're on a subspecialty, maybe there's the cards for the relevant surgeons and consultants down there that then go to their pages, and then vice versa on all the different treatment pages and condition pages, rather than if you had a bunch of different websites, it would kind of dilute the energy. You'd start competing with each other because you'd be using the same keywords and again and again. So I think your current strategy is a great one, and just kind of continuing with that as it is would definitely be kind of my recommendation there.
Thank you. Yeah.
So moving on to some other questions here. What has been your journey kind of with the NHS? Do you still practice in the NHS and have your private practice? What's the balance for you there? And with your academia alongside, like how do you manage all that? And just talk about that a little bit. I'd love to hear more.
Yeah, so I still have a full-time equivalent job, which is 60% NHS and 40% academic. So I've actually been employed by the University of Oxford since 2004, and they've remained my primary employer, and they run my payroll. And then what they do is they sort of subcontract me back to the NHS for my clinical activity. So I work every week in the NHS. I still do on calls in the NHS, but I also have this protected time to do research. From a research perspective, I mean, it all kind of links together. So as I said, my main research is in kidney stones, and all of the research that I've done over the last 10-15 years has all been related to endourology. I do a lot of work with design of instrumentation, modeling. So I have good collaborations with departments like the mathematics department in Oxford, looking at fluid mechanics and modeling of flow. So a lot of our instruments use irrigation, and we've looked at how you could optimize the design of instruments, and we do that often in partnership with industry. So we have really strong relationships with the manufacturers, and they sponsored a lot of really first-class research through PhD studentships in Oxford, and we hope that's going to continue because it's a really exciting field. And in the last, I'd say, 5 years, the rate of acceleration of stone surgical technology has been absolutely phenomenal, and it's been driven by a lot of innovation, mostly coming from China, and there's a lot of companies who develop new products, and they've iterated very quickly, and they've taken new technologies which we wouldn't really have thought of 10 years ago. We've moved a lot to single-use equipment, which allows to add more technology. So we're not reusing equipment and sterilizing it, which means you don't have to worry about any of the technology being damaged by the cleaning process. And it allows us to have really high quality, fresh equipment each time with lots of extra functionality. So things like pressure sensing. We've got now various suction devices to aspirate at the same time as we're lasering. Lots of advances in laser technology. So it's a really, really exciting time for innovation in stone surgery, particularly. So that's kind of where I've been focusing my research. And then, as I say, I still do NHS practice. So again, same sort of practice, mostly stone practice with some benign prostate work as well. So that's my sort of day-to-day thing. And then the private practice sort of sits around that, and then trying to keep everyone happy in the partnership, and making sure we have a good meeting every now and again, and some social events to keep everybody happy and on board with what we're doing.
That sounds amazing. It sounds like you're a very busy man. Balancing it must be a little bit of a challenge sometimes, but it sounds like you're thriving in it.
No, I love it. I really love my job, and yeah, I enjoy the variety, and I enjoy the detail as well. So it's I feel very lucky, actually.
That's amazing. Well, congratulations on that. Kind of just moving on from that a little bit, but in the same kind of area. So how do you think about the role of private practice in the broader UK healthcare system? Is it complementary, contradictory? What are your thoughts on that balance?
Well, private practice has always been around. Obviously, it predated the NHS, and then since the NHS was founded in 1948, there's always been a private practice. I think in the last few years, and particularly since COVID, with the long waiting lists that we know of in the NHS, and there's increasing sort of dissatisfaction with the service in the NHS, people have been looking at private practice as an option. There's also a lot of contracting out from the NHS to use some of the capacity that's available in the private sector. That's not something that's been a lot, not something that's been happening a lot in Oxford, because there's not a huge unmet capacity in the private sector in Oxford, but in some areas of the country, many of the private hospitals have been doing contracts to deliver that work. I think, well, certainly the private practice has grown a lot since we started, and at the moment it seems to be accelerating every year, with more people taking out insurance and so on. I think it's a difficult time at the moment, and next week we're facing another round potentially of junior doctor strikes, resident doctors I should say, and there's a lot of unhappiness around. But I think from my perspective, I think, as I say, I enjoy my job, I enjoy seeing and treating patients and the research, and I think the more we can help and the more we can do, it doesn't really matter which route we go. But I think certainly statistically, I think there's an increase in the private practice year on year, particularly, as you say, in the insured market.
Yeah. And so what do you think the next 5 to 10 years looks like for consultants starting out building their new private practices?
Yeah, I think starting private practice is a real challenge, particularly if you don't have the support of a group to help you. We've onboarded a lot of people into our group over the last few years, and they've said to me on many occasions, well, there's no way I'd know what to do if you hadn't told me, fill out this form, register with these people. This is, all sorts of little things like, do you set up a limited company, or do you operate, as a sole practitioner? There's all sorts of things around running it, which I think you benefit from the experience of a wider group and more experienced people. So I think it is difficult, and it's also, you don't know what your revenue is going to be. So you have all these fixed costs, and certainly I think most people anticipate that it's going to be relatively easy, but we know from the data that probably about 30 to 35% of sole practitioners' turnover is spent on running the practice. So for every pound that you earn, I mean, sort of 35p disappearing in admin and costs, whether that's indemnity, secretarial support, electronic patient record systems, all the rest of it. And then on top of that, obviously, you've got the tax side of things. So you're going to get taxed on that income as well. And you need to work out how you can make that tax efficient, as I say, either using limited companies or other ways of doing it, so that it doesn't impact on other aspects like pensions and all the rest of it. So there's a really complicated financial piece to do, and actually I think a lot of people starting out work really hard and end up with not that much money at the end of it, and so they need to work out whether that's really something that they want to spend their time doing. And there are alternatives. So some people prefer to pick up extra shifts or extra work in the NHS, and it's all kind of run through the payroll and taxed and sorted out for you, and you don't need to worry about sort of running a business, which is what private practice is really. So I think you do need to have either some knowledge of business and running business, or find someone or a group that does, and that will really help you get going in your private practice.
I think that's fantastic and excellent advice, and very much in keeping with what I'm hearing and seeing out there. So last question, what's the one thing you wish someone had told you before you built Oxford Urology Associates?
Gosh, that's a hard one. I think I think it's difficult to answer that, because for me it was a continuous learning process, and it still is a continuous learning process. So, even having done it now for 12 years, every few months, I think we need to evolve, we need to change. So I wouldn't say there's one sort of thing I say, oh, I wish I'd done it differently. Yes, have we done things perfectly? Definitely not. We've done, but also the technology is advancing. So what was around 10 years ago, it's been totally superseded by what's around today. So I think, I'd say I've really enjoyed getting involved in it. I would definitely recommend working as a partnership. If you can find one, then and you're starting out, I would recommend joining it. If you can't find one, think about joining with some colleagues, and setting one up, and be very pleased to help advise if you want to have a chat about that sort of thing. And then I think you just need to kind of, like any business, you just need to keep the team together, keep communicating with the team, and keep looking out for new opportunities to expand and develop what hopefully will be a really enjoyable and successful long-term sort of collaboration, really.
Well, thank you so much, Ben. I mean, what strikes me about your story is, I mean, you've really built something that most people just dream about, and in real practice with real systems, real people, and amazing longevity. And you've done it without compromising clinical work, academic work, and that's really genuinely rare. And so I hope people reading this book are maybe going to be at the beginning of their journey, or maybe a group wanting to come together like you did. So some of them will be sitting in an NHS clinic right now wondering whether it's even possible. I think what you shared today really gives them a blueprint, and more importantly gives them permission to go out there and think about this. But really appreciate it. Thank you genuinely for your time and your willingness to help a lot of people here.
Great. Well, thanks for the interview, Taylor, and really nice to spend some time talking with you.